And the other thing is, you can see at the bottom of your screen, there is a chat option and there is a Q&A option. So you can use both of those options for questions later on. And today we have a really wonderful lineup of speakers. I'm so excited about that. And few housekeeping things. The other thing is you will get to ask questions at the end of the sessions. And after this is over, maybe by tonight, for those of you in India, or maybe tomorrow, you're going to receive an email which contains an evaluation form. Please fill that in and reply to the email from which it is sent. And I think first I'm going to start off with Dr. Sandip Raha. Please, will you introduce yourself? So Dr. Raha is going to talk about Parkinson's disease. And I think in between we will have Shyam come in to introduce the event and what all this is about, because we're just waiting for him to join. Welcome. So Dr. Raha, over to you.
Thank you, Shabnam. I have been practicing Parkinson's disease and movement disorder in UK for the last 20 years. I'm a geriatrician by training, and I did had a attachment sort of tertiary opinion clinic in Medical Synergy Super Specialty Hospital in Calcutta in 2017 and 18. And I still have got some patients with Parkinson's disease in India who I try to advise through Zoom meeting or WhatsApp. In my NHS job at present, I run 4 clinics a week, which are mainly Parkinson. And of course, when you are managing Parkinson, you have to see other movement disorder as well. My today's talk will be mainly a very basic information about Parkinson, how general practitioner, general trainee doctor can recognize or suspect Parkinson, or even family member of people with suspected Parkinson can make some ideas so that they can go for for specialist neurology consultation. And most of my talk is oriented towards what is available in India, not in Western world, and also gives a little brief about the history of Parkinson's disease in Indian perspective. I'm just going to share my screen now. Can you see my screen?
Yes.
Yeah.
Okay. So I'm going to talk mainly about the basic facts. These are my disclosures.
Sorry, Dr. Raha, your PowerPoint has not started. It's we can see your, I think that's your whole screen.
Maybe if you minimize it, the PowerPoint might be open in the background. Just have a look. It may be open, Dr. Raha. Just check by minimizing the documents folder.
If I go on the slideshow, see whether it was. Can you see it?
Not yet.
It says you are sharing the screen.
What screen do you see from your side?
I can see my screen, the PowerPoint slide screen.
Dr. Raha, I have your slides. So is it okay if I start with mine?
Okay, just a second. Let me just try just once more.
Okay.
Yeah, I think Miku may be right that it is open. That's why it's not doing it.
Sometimes Zoom can be...
I think I will go ahead because so can all of you see my screen?
There we are. We can see your screen.
You can see my
Okay.
screen. So Dr.
Yes.
Raha, all you'll have to do is tell me next slide.
Okay, so go for the next slide.
Okay, 1 minute, sorry.
My declaration, I just mentioned declaration, but declaration slide was not there.
No.
Next slide, please. These are some famous faces of Parkinson's disease. Most of you will know many of them. And just to mention that this is Michael J. Fox, who is was a Hollywood actor, and he has generated a Fox Foundation in US for last 20 years, doing very innovative funding for very innovative research on Parkinson's disease and cure of Parkinson's disease. There are some newer faces in this celebrity with Parkinson's, and Jesse Jackson, Bill Connolly from UK. Next slide, please. So I wanted to give a perspective of Parkinson's disease, how it was known in ancient India. It's said in Western world that James Parkinson described it first. But if you look at our Ayurvedic medicine history, earliest reference to slowness, which is bradykinesia, dates back to 600 BC. Charaka proposed a coherent picture of the triad of symptoms called Kampavata. Kampavata basically included tremor, rigidity, and bradykinesia and gait disturbance, which is still hallmark of Parkinson's disease in 21st century. And so PD was described in Western world by Gallen and subsequently by James Parkinson, whose name is put in 19th century. James Parkinson actually never examined any patient. He was an apothecary, that means not a trained doctor, and he saw patients with Parkinson in the streets. Now, if you go back to Ayurvedic medicine, Kampa, which is a tremor, also known as Bhepatu or Atiphanam, and it can be localized, which is Ekanga, and can be generalized, which is Sarvanga. Similarly, Stambha, which is rigidity and stiffness, described in Ayurvedic medicine, can be also localized Ekanga or generalized Sarvanga. And these both together with abnormal pattern of movement are interdependent, and this was described by Charaka in 300 BC. Slowness and akinesia, the Ayurvedic description of Sesta Snaga and Sesta Hani were described as well, and it is documented in Susruta monologues of 600 BC and Dalhana in 12th century. Next slide, please. So gait disturbance, which is Gatisangha, and postural instability is late features of Parkinson's disease. And it is interesting that in ancient Ayurvedic medicine, it was known in 5th and 7th century. And this is still a late Parkinson features as we know today. It is also described that you can have dysarthria or dysphasia, which is a speech problem, and this can progress involving mental health, causing dementia, which is smritikasha, and vishada, which is depression. Now, dementia and depression are two very common features of advanced Parkinson's disease. And actually, in my practice, those two take far more time than actual management of a movement problem in Parkinson. Etiology of Kampavata in Ayurvedic medicine is described as disparity between Udana and Prana. Udana is psychiatric and Prana cognitive dysfunction, and Susruta also mentioned that the poisons like Kalakutavisha or Mustaka may generate rigidity and tremor. We today know there are many chemicals and even drugs which can cause Parkinson-like symptoms. So it's interesting that ancient Indian medicine over 1500 years ago knew about this. And causative element on evaluating Kampavata included physical and toxic impact on mind and body. And there was some treatment available, powdered seeds of Mucuna pruriens, which actually had around about 4 to 6% of levodopa, the gold standard drug we use today for Parkinson's disease. And these powdered seeds were given to the patient, to the suspected patients through Ayurvedic medicine in those days. Next slide. So prevalence and incidence of Parkinson's disease. But if you look at India, although our prevalence is much lower than many Western world, this is per 100,000. So India, if you look at 50-54 age group, 128 cases per 100,000. If you look at over 80 age group, 260 per 100,000 population. But if you look at, obviously, when you consider the population, then India and China, being the two largest population in the world, will have maximum number of patients with Parkinson's disease in year 2030. This is the projection. So India is going to have around about 0.7 million patients with Parkinson's disease, and China nearly 5 million, which is far less than the Western world, although prevalence in Western world is much higher. So this needs to be taken in consideration. And this slide shows the actual demography in the World Atlas. As you can see, India and China in red, which means more than 100% growth. Next one. There are several studies have been published for epidemiology of Parkinson's disease in India. And the urban study from Mumbai, India, 148 per 100,000 population. Kashmir, northern India, 142, and southern India, Karnataka, 76. So these are the studies available in the literature as far as prevalence in India is concerned. Next slide, please. If you look at the case control study, a risk factor of Parkinson's disease in India, as we see in Western world, male sex is a risk factor, almost twice. In my practice, it's around about 1.5 to 1.8 ratio between male and female. Family history of Parkinson's disease makes you around about 10% higher risk of developing Parkinson's disease. History of depression for more than 10 years, your risk goes up by 1.5 times. Well water drinking, more than 10 years of well water drinking, which many rural India still have, increases the risk almost twice the normal population. There are some studies suggesting, previous one. There are some studies suggesting that exposure to pets and smoking is protective, but obviously we can't recommend smoking to prevent Parkinson's disease because of the other health reason. Next one. So this is the genetics of Parkinson's disease in India. You don't need to go through the whole slide. There are the one in the highlighted in bold pattern, PARK2 gene, PINK1 gene, and DJ1 gene. These are the genes which have been known to be prevalent in India. But if you look at the prevalence in all PD patients, they are almost always less than 10%. And the numbers are quite small in these studies. So we need larger studies to look at the genetics and prevalence of genetic mutations of Parkinson's disease in India. Next one. There is a big discussion in Parkinson's world whether having Parkinson's disease reduces your life expectancy. Now, these are the graphs of average life expectancy at the age of diagnosis. So the darker bit are Parkinson's disease and lighter gray is general population. So somebody age 25 male have a life expectancy of another 50 years in Western world, at least 50, 55 years. If they have Parkinson's disease at age 25, then they have life expectancy of 40 years. So it does reduce your life expectancy both in male and female. Next slide. Coming to how to suspect Parkinson's disease. Now, I have done these very basic slides because didn't want to make it high flowing for super specialist. Tremor, shakes, ideally it is unilateral and asymmetrical. So even if the both sides of the body is involved, one side will be more affected than the other. That's how the Parkinson's disease starts. It could be in the upper limb or could be in the lower limb. It's slow tremor and it's rhythmic and asymmetric. It can be pin rolling as well. I will show you an example of that. Mainly the tremor happens at rest and gets better when the affected arm or hand is used. It can get worse in certain posture, and interestingly, it's more noticeable by family and friends rather than the patient themselves. Usually chronic, between 6 to 18 months, could be even many years. Writing can get smaller, crowded, progressive deterioration. So these are the things which family and friends can notice. Voice and speech, quieter voice, flat without modulation, and hesitant speech. Next one. Slowness could be regional, could be local, could be global. So if you have got one hand or one arm slow, then you may have difficulty using that hand or arm. It's not supple, the continuous movement, spontaneity goes. Day-to-day function, patient may have difficulty and clumsiness in doing buttons, holding spoon, cutting or picking food up. Shaving and brushing of the teeth or hair can be clumsy, difficulty in turning in bed. And all these symptoms are worse when they are anxious or tense. Walk will be slow and can be with reduced arm swing on one side. Turning can be difficult. An interesting feature is in some patients with Parkinson's disease, if they're going downhill, they have difficulty in stopping at certain spot. Next one. Sense of smell. I ask this question regularly to my patient. Either it is lacking or they're losing sense of smell. Studies have shown nearly 60 to 70% patient lose their sense of smell or they lack their sense of smell. Obviously, with COVID around, where sense of smell goes, it's not the same because these are people losing their sense of smell for many, many years. Bowels slow and constipated, which can go back to 5 or 10 years before the diagnosis. They may have a history of low mood, depression, lack of interest and concentration, difficulty in falling or staying asleep, and in some cases, dreams and nightmares, new onset. There is a condition called REM sleep behavior disorder when the patient's bed partner describes thrashing, screaming, shouting, hurting in bed in sleep. That's particular sleep disorder is a high risk for Parkinson's disease. Next one. So it is a complex disease, includes genetic, acquired, and environmental components. Age is the biggest risk factor. Highest age decade range for risk is 60 to 70 years. It's more common in Europe and North America than Asia and Africa. Family history, I mentioned about male sex, exposure to heavy metals and pesticide, and steelworker employees. I have got a big steelwork factory in my catchment area of hospital, and I have got many patients from there. Difficult to prove, but there is evidence that heavy metal deposition over many, many years makes you more at risk for neurodegenerative disease like Parkinson and Alzheimer's. And I mentioned about loss of sense of smell and constipation and REM sleep behavior disorder. Protective smoking, coffee. Interestingly, coffee is quite unique because that itself is a different talk. But I have over 600 to 700 patients with Parkinson. None of them have been smoker ever, and very few of them actually drink real coffee. Next slide. So this is just a pictorial, and not every patient will follow this trajectory in years. And we are talking about this trajectory over 10, 15 years in most cases. Those who have postural problem, they actually do worse than those who have got shake problem. Next slide. So coming up to treatment now, what is available in India, the gold standard treatment of Parkinson's disease is still levodopa. Levodopa comes as a Syndopa, Syndopa Plus, or Syndopa 110. And this has been available, levodopa has been available for over 50 years in Western world, and still it's a gold standard treatment. Disadvantage of levodopa is that it has to be taken 3 or 4 times a day because it's a shorter acting. So you get fluctuations in control. Dopamine agonist is the next group of drug, which are long acting usually used, and pramiprazole, ropinirole, both are available in India as extended release. I have put the actual pharmacological name, not the trade names. MAO inhibitor called selagiline or asaziline are next medication. They are quite weak anti-Parkinson drug, but they have been given, can be given once a day usually. And COMT inhibitor, which are entacapone, usually mixed with Syndopa. They don't work on its own. All these inhibitors basically reduces the breakdown of levodopa and deliver more dopamine to the brain. Amantadine only when there is a levodopa-induced movement problem and fluctuations. And you can have combination permutation of above drugs. My aim in practice is to try to maintain some sort of continuous dopaminergic stimulation in the background by using long-acting medication right from the beginning. So I tend to use levodopa as the first line, but once the patient needs more than 3 times a day or increasing the dose of levodopa, I tend to add on a long-acting medication in the background. Deep brain stimulation is available in India in quite a few centers, and I will show you a little bit more about that. And it's a neurosurgery, mainly given for people who have got uncontrolled tremor or dyskinesia, which is the levodopa-induced abnormal movement. It doesn't really work very well if you have got falls and gait problem. And I mentioned that before any other medication in terms of India, because it is available in India, deep brain stimulation surgery. Apomorphine, which is not a morphine, but a morphine type analog, is very strong anti-Parkinson drug, only available in injection form, but not yet available widely in India. We use in UK and in Western world quite extensively, but has to be delivered through a continuous subcutaneous pump. Next slide. There are some caveats to treatment. In particular in Indian context, the patient has to be counseled properly that it's a lifelong treatment. They have to take their medication regular interval, and that's very important. If they take it in empty stomach, levodopa works better, particularly first thing in the morning. Treatment for constipation, depression, and the mood is important. And one of the common pathway of improvement is physiotherapy. There are studies showing physiotherapy does improve dopamine delivery in the brain. If the sleep is affected, that needs to be managed. So patients should be encouraged to have routine, follow a routine and exercise regularly, drink enough fluid, keep under their specialist regularly, and in later stages of Parkinson's disease, driving probably is not recommended. Although I'm not aware of what are the regulations in India about driving, but I have seen a very complex patient, young IT consultant in India who is still driving, and he has got very abnormal movements and had deep brain stimulation implant as well. So when I raised the question of driving with him, there was a big silence. In Western world, those are automatically managed and advised. Next slide. So I'm just going to play a little video of this gentleman. Can you walk towards me? Stop. You can see the pin rolling tremor in his hands, and his posture is flexed. And face is not showing very well. Face is a little bit flat and masked face. Turn round. Go back to the door. The turning takes round about between 4 and 6 steps, but this is very early Parkinson. Okay, Shabnam, you can stop that now. Next, go to the next one. Next slide. Yeah. So let's talk about deep brain stimulation. Deep brain stimulation is a advanced treatment for Parkinson available in India, particularly in southern India, like Hyderabad NIMS has done quite a lot of deep brain stimulation implant. It's available in Calcutta as well, but I'm not very sure about the results there. And basically, patient have a MRI brain, which actually localizes their basal ganglia and subthalamic nucleus. And it is then computer and generated lines, and under general anesthetic, at least in Britain is general anesthetic, patient have microelectrodes put in after a burr hole, and that electrode goes to subthalamic nucleus. The electrode got multiple points of stimulation, and it can do 360 stimulation as well. And you can monitor which points will be stimulated, and then it's connected from outside with an extension wire and a pulse generator. And pulse generator is just like a pacemaker. And this pulse generator gives electrical stimulation to the subthalamic nucleus, which is the amplitude and the frequency of the stimulation is set by the deep brain stimulator center, and it has to be regularly managed and followed up by the center. The generator does run on batteries. There are modern ones which can be charged from outside, and the older one, battery needs to be replaced every 5 to 7 years under local anesthetic, taking the generator out and replacing the battery. Very effective treatment for late Parkinson's disease, particularly those patients who have got mainly tremor and dyskinesia, which may not be able to be contained by oral medication. In Britain, my practice is I have got over 15 patients who had deep brain stimulation implant. My practice is that we try to optimize their medical treatment. We use apomorphine injection, which is a continuous pump, and failing that, we do the deep brain stimulation referral to the neurosurgery. And because in UK, it costs around about £30,000, but that's covered by NHS. In India, as far as I know, in South, particularly in Hyderabad, it costs between 5 to 7 lakh rupees. But the follow-up is also quite important. Next slide. I will just show you a video of this gentleman who advanced treatment. David, he was diagnosed at the age of 27. Can you tell me your name, please?
David Hoover,
And how old are you now?
37.
Okay. And tell me about the history of your Parkinson at what. So he was diagnosed at the age 27. After 9 years of treatment with oral medication, he went for deep brain stimulation.
And I was 25,
Yeah.
and I was playing rugby on.
So he had a right side impalement.
My hand open. They hurt my hand, and they went up from there all the way up to my arm. They thought the muscle gone, and they went up to my shoulder and into my brain, and that's how they found Parkinson's disease.
So you had the right side was affected, yeah?
Yes.
Your right side. So right side was slow or clumsy?
And it's like I was holding and playing rugby, and my father noticed it.
Okay. Okay, can you just fast forward a little bit, Shabnam, fast forward the video? Yeah, wait there, that's fine, yeah. Replay, yeah.
No, I had to prevent. That's the way I was comfy at the back.
So the posturing he is showing, that's what he had with levodopa. He had marked dyskinesia. At that stage, he didn't want apomorphine. She doesn't want to be filmed, but let's hear from her. Can you describe those movements David used to have?
Yeah, it used to be very bad. The movement was
Were they controllable or uncontrollable?
uncontrollable. Used to take tablets, but sometimes I used to make it worse.
That's levodopa making dyskinesia worse.
Right side used to be worse than the left. A lot of movement in his right arm and his leg.
And how did that affect his day-to-day and mobility, those movements?
Terrible. Couldn't hardly do anything. Couldn't go out. Because obviously people used to stare at him as well.
Okay. So let's fast forward for another 3 minutes. Yeah, that's fine. So he went to have the deep brain stimulation implant. Stay in hospital and all that.
I was in 2 days, or 2 days, yeah. The first day, they put a clamp on my head. I was under for 4 hours there. You know, and I only done 4 hours. Then the next day, and I was in the 5 hours in. But
so he's describing the clamp on his head. That's the MRI under the clamp. Were you anesthetized when those all the axis and depth can be measured. Surgery. Did you have to go to Bristol, the center you had the surgery beforehand?
Yes,
for assess?
I went up twice. I did. Because so you got to have it done before.
Went to Bristol twice for assessment pre-surgery.
I go back up to do it again, and I had me in there 2 years ago.
Okay. And do you still go there for checkups?
Yes.
What sort of checkup they do then?
I just now walked out there, and I just got there like not taking my time.
Showing that little gadget he was holding earlier. That's the stimulator to be switched on and off from outside.
With the tablets on, and that's it then.
Okay. So you have just switched off your DBS stimulator. So what we did, we switched off his DBS while he was in my clinic to see the effect. What effect it has when he has no DBS. So we just see what he's like now without the DBS implant. Switched off the DBS now for last 30-40 seconds now, coming up to a minute. How are you feeling now, David?
Stiffer now.
Stiffer. Your voice has gone a bit quieter. Leave the control outside. We'll just do the hands again. Can we see the movement of the hands? Put your hands out. Put your hands out. Fingers apart. Can you open and close your fist as quickly as you can? You can see the right side is much, much slower. Sorry, we may have missed it when it was switched on. Two finger tap both hands. Video is not streaming very smoothly, I'm afraid. Your left side is also slower, isn't it? Looks like it. Yeah. And we try to stand him up now. Can you put your arms across your chest and stand up? See whether he can stand up with arms folded. Now can you go across, just get the arms down, go across to the door. And back now. You think you're much slower? Yeah. Back now. Okay. All right. Sit down now. Yeah, the streaming is stuttering, but there we are. Okay. Not so sure. Now he's even more slower after the switched off DBS. His partner has to help him to stand. And difficulty walking, don't walk then. You are not sure you can walk. Much, much worse. Okay, that's right. So go and sit back. Go and sit back. You are not actually able to walk like you did unaided. So that was when you couldn't stand up at all, and right side was very, very rigid and stiff when you switched off the stimulator. Yeah, David? Yes. And how you're back on the stimulator on again. So how are you feeling now? Better now. And you think, put your hands out again and then do the open and close fist. Do it quicker. Okay. And can you actually open and close the fist like that? Keep going. Okay. The video is not streaming as it was on my computer. It's streaming much, much slowly. Okay. So I think we can stop that, Shabnam. So I think we've come to the end of my talk. We can take the questions. I don't know whether to take the questions now. I think it will be better because the second talk is a different topic. So questions.
Dr. Raha, can you see the questions in the chat box and the Q&A, or would you like me to read them out?
No, I can see them.
Okay.
The first one I see that is the low prevalence due to poor or late diagnosis. Yeah, I think it could be part of that. It's obviously a lot of people in villages and smaller town may not have access to the neurology consultation. And on the top of that, they may think it's due to aging process. So these studies, which are based obviously in secondary care setup, are not particularly population studies. So we need better studies. Reason behind well water drinking, I think. So well water drinking usually got heavy metals on it, aluminium and iron. So those are the two as far as I'm aware of. Is there an age threshold for onset of symptom? As I said, that the age is the biggest risk factor of Parkinson's disease, and it is far more prevalent in older age group. More so because we all are losing our neurons and cells as we're getting older, and the production of dopamine actually goes down as we age. That's a normal process. So once you cross that critical level, around about 60% loss, then you start getting the symptoms. So age is, there is no age threshold needed for diagnosis, of course not, yeah. Can acupuncture help? I'm not so sure about that. I don't actually have access to alternative medicine in UK, but some of my patients have actually benefited in terms of their tone and rigidity of particular limb. going to private acupuncture. I can't see any others, to be
There is
honest.
one more question, Dr. Raha, in the Q&A. Does continuous consumption of levodopa increase constipation?
Okay, that's a very good question, actually. The way the constipation happens in Parkinson's disease, it's a similar, I explain to my patient, like your body is slowing down outside, your body also includes your bowel and your small and large intestine. And there is enough evidence in research that there is slow colonic transit in Parkinson patient. So if you have a slow colonic transit, the normal age matched, age sex matched in Parkinson, that will affect. In addition to that, there is also this gut microbiota theory, which is another talk altogether. And gut microbiota does affect the absorption and processing of levodopa. So levodopa doesn't cause constipation. Levodopa should improve constipation. But if you are very constipated, then levodopa may not get to your brain to work. So you may think that levodopa causing constipation, but it's a failure of levodopa absorption and assimilation to get to the brain. There is another question, can farmer get it from fertilizer like organophosphate? Yes, of course. That was one of the reasons that farming community have higher prevalence of Parkinson's disease in Britain, even because in Britain, farmers used to use organophosphorus back in 50s until early 60s. So I have got many patients who were farmer in their younger age group, and they are in their 80s now, or even early 90s. So organophosphorus has been banned now, but inhalation of organophosphorus.
Dr. Raha, there's one more question. I think that will be the last one for your section. Does the
Okay.
well water impact on people all over India?
Sorry, say it again.
Does the well water impact on people all over India?
Not all over. I mean, well water, most of India, town and even smaller town, and particularly certainly urban areas have got tap water now, isn't it? So if you've got tap water supply, but on the other hand, we don't know because a lot of smaller places, like my brothers live in small town called Ramgarh near Ranchi in Jharkhand, and their main supply in summer months, dry months, is a deep bore water through pump. So whether deep bore water got the same problem with well water, we don't actually know that. It could be because it's coming from deep inside the soil, but certainly tap water don't have that risk.
Dr. Raha, just one question. So these studies that you were quoting, they were basically association studies, right? They didn't show the causation. And will you just explain a little bit for people who don't understand the difference between an association study versus a causation study?
Yeah. You basically, in association, you just look at the prevalence, isn't it? That certain amount, certain type of people in certain community and certain environment have higher prevalence than the comparable population. But that doesn't mean causation, it's association, yeah.
Okay, I think we will move over to the next section. So the next
Thank you
section.
very much, thank you.
Thank you, Dr. Raha. That was excellent. And so the next section, the moderator is Dr. Chinmay Maity, and the speaker is Dr. Siladitya Sinha. So Dr. Maity, I'll let you take over. Please, will you introduce yourself and Dr. Sinha as well? Over to you. And sorry, go ahead. One question someone had about the video and the audio. So the attendees are all on listen only mode. So you cannot turn on your audio or video. I'm sorry about that. But okay, Dr. Maity, over to you.
Can you see me?
Yeah.
Hello?
Yes.
Yes.
Yeah.
Hello, Dr. Maity. Clearly visible.
Good evening, my dear. Good evening, my dear colleagues, friends. Welcome to this. It's a good evening. At first I must thank the organizer, the Trinnect Limited, for inviting me to this international webinar on Parkinson's disease and frailty in the elderly. Dr. Raha gave a very nice talk on Parkinson's disease in the older people with nice question answer sessions. The next session is on frailty in the older adults. I, as a moderator, am going to share a few slides before the next speaker, Dr. Siladitya Sinha, will discuss on frailty in primary care. I am working as a senior consultant physician and geriatrician in Medical Super Specialty Hospital and AMRI Mukundapur for last 5 years. Before that, actually, I worked for 6 years in Apollo Gleneagles Hospital, Calcutta. And before that, I had 15 years of my career in UK. So I started with a SHO job and then registrar. Then I was a consultant before leaving. Before he came back to India in 2009. Here actually, I'm seeing, doing my general medicine clinic, and sometimes I see a lot of elderly patients, but not particularly in a separate geriatric clinic. But we are seeing all sorts of patients with all geriatric issues. And my topic is on frailty. So I am sharing my slides.
Dr. Maity,
Can you see my slide?
Oh, we can't see your
Hello?
screen. Can you share screen? And I think your phone, is that your phone? Can you go to the share screen at the bottom of the screen?
Yeah, I'm just going, just a second. Yeah.
Shabnam, maybe we do the same thing again because Dr. Maity, your bandwidth is showing low every now and then.
Yes.
So that may be part of the problem.
Dr. Maity, I can start your PowerPoint slide and you can just let me know how we did it for Dr. Raha. You can let me know when I should go to the next one.
Should I off then? Just a second, let me just try once more, probably.
Okay, this is my screen.
Just a minute. Yeah, is that?
This is my screen and your slides, and you can tell me when to go to the next one. No problem.
Okay, thank you. Yeah, go to the next one, please. So the topic is frailty in the elderly. And so before going into frailty, we all know that the life cycle of any living organism has 4 stages: birth, growth, getting older or senescence, and ultimately death. So frailty, the literal meaning debility, is an inherent part of senescence and not confined to human race only. Frailty was there since beginning of life and of course the human race. Evidence from the past. I think as Dr. Raha mentioned about Ayurveda and 1500 BC, it's the same thing actually. 1500 years BC in Ayurveda, there was a separate branch of medicine called Jara or Rasayan, which dealt with the disease in the old age. And in Jara or Rasayan, the different aspects of old age, including frailty, been discussed in details. In 600 BC, in the life history of Gautam Buddha, we have seen that young Prince Siddhartha, in his city travel, he saw he actually encountered 4 incidents in 4 consecutive days. The first day he saw a very old man walking on the roadside. He was too old to walk. And the next day he saw a very, very ill person who was about to die. The third day, he saw someone dead, a dead body carried by the relatives, and they are all crying. So these 3 incidents moved young Prince Siddhartha too much. And the fourth day, he realized that this is the ultimate fate of life. And the fourth day, he saw a very happy person, a monk, walking on the roadside. So actually, after these four incidents, his life changed completely. He decided to leave his kingdom and leave his family life, and he wanted to be a monk in search of God. But anyway, so in that period, what he saw actually the first 3 days, those are the consequence of senescence or old age features, very old, ill, death, those sort of things. In 1600 AD, there is a vivid description of a frail elderly man in William Shakespeare's novel, As You Like It. So in different ages, we have seen that the frailty was there, and that's been described in different forms. So please go to next one. So I'm a few slides actually I'm showing you. There is a 66-year-old female who is confused and unsteady, and she has limited mobility due to advanced osteoarthritis of knees. Who is this lady? Next, please. She is no other than our Ma Saroda. Next one, please. So, 87-year-old female who is confused, disoriented, and incontinent. Who is she? We all know she is our Mother Teresa. The next slide, please. 76-year-old male, confused, falling, and incontinent. And he is no other than the all-time great scientist, Einstein. Next one, please. 95-year-old male, forgetful, confused, incontinent, and unsteady again. And he is no other than Nelson Mandela. What is the last one? 80-year-old male, confused, incontinent, and unsteady. And he is no other than our dear Kaviguru Tagore. And then I'm showing you a couple. Both of them are forgetful, confused, incontinent, unsteady, and occasionally falling. Who are they? So they're both of them are in their 80s. One is 87 and one is 81. The gentleman is a farmer and his wife. Carry on, please. They are parents of 4 children, 2 sons, 1 doctor and 1 engineer, 2 daughters, both of them are professors, and all 4 are living away. The gentleman is walking with a stick, but his wife can walk unaided. They have 2 carers at home. The support system includes housemaid 1 and a cook. So next slide, please. So what are common to all of them? They are all aged more than 65-year-old. They have contributed to the society or humanity in their own respective fields. All are suffering from what is called frailty syndrome, or previously well known as geriatric giants, described by Bernard Isaac in late 20th century, which includes immobility, instability and falls, incontinence, and impaired memory. What they need a proper diagnosis, treatment, and care of their ailments with dignity, respect, and love. Next, please. Now coming to frailty. It's a common geriatric syndrome. It means the condition of being weak and delicate. The dictionary synonyms are infirmity or debility. The definition of frailty. Frailty is a geriatric syndrome resulting from age-related cumulative decline across multiple physiologic systems with impaired homeostatic reserve, and a reduced capacity of the organism to withstand stress, thus increasing vulnerability to adverse health outcome, including falls, hospitalization, institutionalization, and mortality. Next, please. Just an example of reduced homeostatic reserve. If we see there are two patients, one is 30-year-old and a 70-year-old, both of them are male, 72 kg, the same weight, and they both have a creatinine of 1 milligram. per deciliter. But when you calculate the GFR, we see that the 30-year-old man has got a GFR very much normal at 110 ml, but the 70-year-old gentleman has a GFR of 70 ml. That means he is in stage 1 CKD. So this is the reserve. The young man has got a 110 ml GFR, whereas with the same thing, this 70-year-old with so-called normal kidneys, his GFR has gone down to 70. So this is the effect of age, and so he has got much less reserve than the younger man. Frailty in the elderly. So the criteria or how we diagnose frailty. So the commonly used scales, John Hopkins or Linda Fried John Hopkins criteria we use. The presence of 3 or more of the following characteristics defines frailty. The first is the unintended weight loss, which is about more than 4 kg weight loss in last year. Weakness, we normally assess that with grip strength and which should be less than 20th population centile. Self-reported exhaustion or lack of energy. Slow gait speed is defined as lowest population quartile on 4-minute walking test. And low physical activity, such as the persons would only rarely undertake a short walk. And there are different indexes as there, like a share frailty index, and so many actually, if we find it's there. Next one, please. Pathophysiology of frailty. Pathophysiology of frailty is multifactorial, involving dysregulation across many physiological systems. No single disease state is necessary and sufficient for pathogenesis of frailty. Frailty is considered a critical mass of physiologic impairment, and the physical components include sarcopenia, osteoporosis, and muscle weakness. Next, please. Okay. The general concept of frailty, however, goes beyond the physical factors to encompass psychological dimensions as well, including cognitive status, social support, and environmental factors. The prevalence of frailty is about 15% in the community dwelling elderly, and it's about double, that is 30% in the institutionalized patients. The incidence increases with advancing age. So age is the most important factor. Then female sex is more common than male. Lower socioeconomic status is also a risk factor. And presence of chronic comorbid conditions like diabetes, COPD, chronic degenerative neurological conditions, including Parkinsonism, we discussed today. Next, please. Sarcopenia. Sarcopenia, actually most, if not all, patients with frailty also suffer from sarcopenia. So what is sarcopenia? The term was proposed by Erwin Rosenberg in 1989. Derived from the Greek word sarx means flesh and penia means loss, so loss of muscle. Sarcopenia is the syndrome characterized by progressive and generalized loss of skeletal muscle mass and strength, with a risk of adverse outcomes such as physical disability, poor quality of life, and death. The criteria for diagnosis of sarcopenia, according to European Working Group on Sarcopenia in older people, is as follows. The criteria 1, that is low muscle mass, must be there, plus one of the 2 or both, means 2 or 3 together or any of them. So low muscle mass plus low muscle strength, or low muscle mass plus low physical performance, or all 3 together. Can I? Yeah. Sarcopenia categorized by cause: primary sarcopenia and secondary sarcopenia. Primary sarcopenia is an age-related sarcopenia. There is no other cause evident. About 1 to 1.5% of the lean body mass is lost annually after the age of 50 years. The mechanism behind is degenerative loss and atrophy, which is apoptosis of the muscle fibers. Sometimes sex hormone deficiency and mitochondrial dysfunction, etc., may be the underlying cause. Secondary sarcopenia can be caused in 3 ways. Disuse, means not using the muscles for a long time, like in bed rest, sedentary lifestyle, deconditioning, and zero gravity conditions in space shuttles, etc. Disease related sarcopenia associated with advanced organ failure states like heart failure, lung failure, liver, kidney, and brain, inflammatory and autoimmune diseases, malignancy, and various endocrine disorders. And nutrition related sarcopenia, also malnutrition, inadequate dietary intake, are also responsible for muscle loss. Sarcopenia staging criteria, if it's less than 2 standard deviation of gender specific mean skeletal muscle mass index for young adults. So stage pre-sarcopenia, where there is only loss of muscle mass, but no loss of muscle strength or performance. So then only pre-sarcopenia. When sarcopenia, so there is low muscle mass along with one of the two or both of low muscle strength and performance. And in severe sarcopenia, all three are there. So next slide, please. So assessment techniques for assessing sarcopenia. So I think in clinical practice side, we will discuss. This is bioimpedance analysis, DEXA scan, hand grip strength for muscle strength mainly, and for physical performance, we usually use usual gait speed or sometimes get up and go tests. Next, please. Go to the next slide, please. Okay, so prevention and treatment. Prevention and treatment of frailty. So healthy lifestyle is the cornerstone to prevent or delay development of frailty. So the elderly people, they need proper nutrition, regular aerobic exercise, and progressive resistance exercise is important to maintain the muscle mass or delay the loss of skeletal muscles. Adequate rest, sleep, and stress-free life, and no smoking, drinking, or any other habits. Regular and adequate treatment of all chronic comorbid conditions are important. Timely intervention for acute medical conditions will also prevent further progress. Hormone replacement therapy and testosterone therapy may be beneficial in a small selected group of patients, but the decisions to prescribe this need to be based on a careful risk-benefit evaluation. Next, please. I think the one slide is missing here. So in Indian context, I'm telling, in Indian context, this is very important because India is a developing country with a huge population, about 1.4 billion at the moment. And we have got a increasing elderly population, which is about 12% above the age of 60 years. So that means we have more than 15 crores, 150 million elderly people in India. And of them, about 80% live in the rural area with no or minimum geriatric, no geriatric care. And 40% live below the poverty line. And 90% of them have no official social security. So as we discussed in case of frailty, the low socioeconomic group and elderly, they are more at risk of developing it. So in Indian context, the frailty syndrome is a huge problem, and it will be a very difficult things to address. And so thank you. If any question, I will answer now, and then I'll introduce my next speaker. Or I think we will discuss, Dr. Siladitya can discuss, and then we'll.
Question after Dr. Sinha's presentation. Maybe you can just, it will probably be answered in his presentation anyway. And
Okay.
Dr. Maity, will you please introduce Dr. Sinha?
Okay. So my next speaker is Dr. Siladitya Sinha. He's a primary care physician, that is GP in primary care in Cardiff in UK for last 5 years. He trained as a reconstructive hand and upper limb surgeon, but had to move to general practice due to some health reason. His interest is in musculoskeletal problems, frailty, and involvement of a community in their healthcare in a holistic way. It's to Dr. Siladitya Sinha, please. Please go ahead.
And I can't resist it. I do have a slight problem that I have a sense of humor. So I must say that that's a mighty talk that I have to follow up with. And it is really important for us when we talk about frailty in the Indian context, because other than the experiences of our elderly relatives, it's not something that I am dealing with day to day. So people like you are absolutely essential. So let me see if I can get the slides up.
Dr. Sinha, don't worry if your end doesn't work, mine is ready, but I think yours will work.
Is it working?
No, we can't see your screen.
Okay, so all right, then I'll let you do that bit.
Okay, I'm sorry if there was some glitch that I created with based on the settings or something like that. I am sorry about that.
Don't worry.
Okay, so can everyone see my screen now?
Yes.
Okay.
Okay, so yeah, if we go back to that previous one, Shabnam. Thank you everybody at Trinnect for inviting me to talk about frailty. Why am I talking about frailty? Because as a primary care physician, it's an extremely important topic. A fair chunk of our patients actually are frail, and that fair chunk of patients have a very large list of problems to deal with. So even if proportionately it's less than the vast majority of the rest of my patients, when we look at our workload, it is quite significant. So I am a GP. I used to be a reconstructive hand and upper limb surgeon, but then after I needed reconstruction myself, I had to move to a slightly different specialty and retrain. Dr. Raha was very keen on a disclaimer. So there's my disclaimer. No frail citizens were hurt during the making of this talk. No money changed hands during and for and around these talks. And there are no conflict of interests. But what I hope is that this is an interesting talk which will leave you with no conflicts whatsoever. So if we can move on. Okay, so a lot of this, Dr. Maity, you already mentioned, and a lot of it follows on from Dr. Raha's talk. So yes, what is frailty? It is more often than not a geriatric syndrome, but it is something that I will talk about a little bit later. It doesn't have to only be a geriatric syndrome. So usually it results from aging, and the body's physical and psychological reserves start to decline. And everything you start to develop a critical mass of problems, and it is progressive. But the real issue is that it makes the person who's experiencing this old man who's sitting all by himself in a chair somewhere, makes them very vulnerable to normal stresses and strains of life. So a little urine infection, which we'd be able to laugh off, might be a very critical incident in their life. So as somebody who's frail, who's built up this mass of various different conditions, they've all accumulated, and it's crossed a critical point, a tipping point. Even normal stressors can lead to adverse health and life outcomes. So next slide, please. So here we are. I was looking for a nice graph. So have a look there. You have different people in different stages. So you have those who are managing well, which is the green line, and you have a stressor dropping down from the top. But they have responded to the stressor. Their body's safety, fallback, so-called homeostatic mechanisms help them fight back. And whatever be the stressor, fall, injury, an infection, they're able to bounce back. But then you have somebody who's slightly frail, whose body systems are just starting to fail. They have a bigger dip after that same stressor. And if you look at that line carefully, this is the middle group, you'll find that they don't come back to the original starting point. Yeah, so they do bounce back, but they don't bounce back to that same starting point. But then if you have the severely frail people who are right at the bottom, then that same stressor sadly pushes them into negative outcomes, both while they're immediately reacting to it, but also to their health status afterwards. They just can never come back to their normal level of function, their normal level of independence. So this is where frailty is a very important thing. It's a loss of resilience, and it leads to greater dependence on and a much bigger set of needs for these people. So if we go on to the next slide. And as Dr. Maity said, we talk about the Indian population and we talk about the population pyramid. Yes, as India grows massively, there are lots of young people. If you look at the Western world, you have France over there, and right at the bottom, you have Japan, where the population pyramid is a complete reverse. So you have very few young people and a lot of elderly people. So what that means is there's a huge stress from various ways. First of all, there are many, many more people who are likely to be frail and likely to have significant health conditions and have significant health needs. The country's health system is more challenged because there are less young people who will be able to contribute to the finances of the nation and be therefore able to help with them. But equally, there'll be less younger people who'd be able to look after these frail people in the society. And this is worsened by changes in living. So as families get more nuclear and smaller, in a funny way, it exposes people to bigger problems of the frailty. So I came up with this statement somewhere from the health ministry. An older population is indicative of how far India has come with regards to its improvement in health indicators. However, unless action is taken, an older population could also serve to highlight the gaps and weaknesses in India's public health system. So, and there was this article in Economic Times, which I found, which talked about the demographic time bomb. It says, yes, it's a young India, but it's actually aging a lot faster than expected. And as we find with the Western world, it's a bit like an exponential curve. It just goes boom. And when it does go boom, you have an increasing number of vulnerable elderly with their vulnerabilities, but also, like Dr. Maity said, financial vulnerabilities, housing, psychological issues. And you already mentioned this, a health system that is skewed towards the cities. And also, sadly, there's a lack of awareness about things that can be done. So there's a big issue about, is there a system that can cope? But coming back, can there be a difference between aging and frailty? Here in Wales, a bit like the Lata Mangeshkars of India, we have a singer called Tom Jones. And he comes on something called The Voice, and he's in his 80s. And every time he comes up, Dr. Raha's wife pops, wow, Tom Jones on Facebook. Because this gentleman is in his 80s. He can sing with a very loud voice. He clearly remembers his past very well. He's clearly extremely excitable. He can clearly get up from a sitting position very quickly. So he may be 80, but he's not frail. So there may be a difference between aging and frailty. And I'll talk about my 3 patient interactions from Friday in a little while. So next slide, please. Okay, so aging. Americans have a habit of making everything simpler. Cricket becomes baseball. Aging drops a E. It's a process of becoming older, yes, but normal aging is not a disease. You can age normally with health conditions, but still actually cope quite well. So chronological age and physiological age are different, and frailty links up to physiological age. So this is where it's important to think about the trajectories of aging, and different people age in different trajectories. We go to the next slide. So it's a spectrum. So I may be whatever I am, 52, but there might be somebody else who's 52 and, oh, I'm 51, by the way, much younger and fitter than I am. So I may be physiologically 57, that kind of a thing. So it's a variable thing. So you have usual aging, where there may or may not be an overt health condition. Successful aging, where some people cope extremely well and maintain their activities and support system without any functional loss. Or sadly, you have the aging with disease and disability. So if we go on to the next slide, we'll go very quickly through this because, and these slides will be there anyway for anybody who is interested. There are various ways aging and frailty happen. It could be just a programmed condition where different body systems pack up as we go along. Errors start to creep up. So there are more and more errors in different organ systems. Then there's the genetic problem. The telomeres help genes divide and therefore help self-division occur. But as one gets older, the telomerase, the enzyme that helps these telomeres come up with the genetic division, start to reduce in their amount. And finally, there comes a time when cell division stops. So an old body just doesn't have the reserve. And as you can see, it affects all organ systems. So again, it affects your eye. So if you can't see very well, then you're more likely to trip and fall and injure yourself. If your endocrine system is not working well, you might have severe diabetes with its risks. You might have a poor proportion of testosterone in your.
Dr. Sinha, we can't hear you. Hello? Hello? I don't know whether it's a problem with at my end.
Systems.
Dr. Sinha, I'm sorry, there was some technical glitch at my end.
Okay.
I'm going to go back to sharing the screen again. And Dr. Sinha, maybe
All right.
keep speaking while I figure this out. So,
okay. Well, what I'd do is, oh, brilliant. There we are. Yeah, we are up.
Yeah.
Okay. So we'll go quite quickly through these because Dr. Maithi's already touched on them. So again, with age, every system starts to break down. So when we think about the heart, again, because the quality of the connective tissues that make up the vessel walls and the heart as a pump starts to get stiff and weak, you start to get heart failure, the blood pressure rises. Also, the control mechanism of the heart, which controls the heart rhythm, that starts to develop problems. So there can be all kinds of funny heart rhythms, atrial fibrillation being a common one. Similar with your lungs, the lung walls and the chest wall itself is not very compliant, not very flexible. So one doesn't breathe very well. Everything starts to get a bit stiff. And the amount of oxygen that gets transferred from air into your blood vessels starts to drop and drop and drop. But sadly, the body's feedback mechanism has also started to fail. So the body doesn't quite respond very well to this dropping of oxygenation. Equally, protective mechanisms like cough, everything fails. So you're more likely to have chest infections, but equally aspirations and all these other problems. We go to the next slide. So we'll go through this bit a little bit quicker. Dr. Maithi's already mentioned GFR, which is a very good overall estimation of how the kidney is working. And when we look at the GFR or the eGFR on our blood results, we look at the age of the patient because that's what is important. So we know that sadly with age, the kidney size starts to shrink, but also the actual functioning glomeruli. So the kidney at the end of the day has all the breakdown products, which if they stay in our bodies, that starts, and two things, that in itself is not good for the body, but also the medication that the person has to take then starts to become a factor because much higher levels stay back in the blood, causing more side effects. So we go on to the next slide. Similarly, as we talked about Parkinsonism already, the neurological problems which lead to tremor, sleep cycle issues, which then lead to tiredness through the day. And then, of course, dementia is a big issue. We go on to the next slide. The other thing that a frail person, especially an elderly frail person who has started to lose their cognitive ability, their ability to think through things, to remember things, they're also very prone to something called delirium as well. So delirium is different to dementia, and a delirium is a state of confusion which happens when a person is not well for various reasons. And these are common causes of hospitalization. So if we go to the next slide. So I like that always. So I keep that in my room, just so I can remember to ask. When we look at a confused elderly person or a confused frail person, it's very important to think about common things. Pain and the management of pain. Are they having too much medication? Are they in too much pain? Do they have an infection? Are they septic? Constipation, cheap and cheerful constipation, awfully common with the elderly, but a big cause of delirium. Are they dehydrated? Again, I mentioned medication, so that's always important. Also, it's the environment in the Western world. Have they been exposed to too much of cold? Have they just not been sleeping well at all? But certainly in the Western world, but I'm sure also in India, it's alcohol. And that feeds in not only to delirium, but also to something called the falls risk, which is one of the big problems that the elderly have. And then you also make sure that they're being able to respond, because they might not be able to respond if they can't hear you or see you. So what's their vision like? What's their hearing like? When people start to age, they like to hide themselves in a cloak of invincibility. So they try to hide the deficiencies and play them down. They don't like people to find out about the weaknesses that have gradually crept up in their life. So one has to be very careful to see through that. So if we go on to the next slide. We mentioned this before. Again, lots of weaknesses in the endocrine system, which for women can affect bone quality quicker than men, but also mood and various other pores. Slightly later for men, it's andropause, what's called somatopause. So these are all endocrine systems which are gradually failing, but they're there for a purpose. These hormones are all there to help maintain body systems. So when they fail, the organ systems start to fail as well. So if we go on to the next slide. And this is kind of really important. So sarcopenia, as has been mentioned, muscle strength, muscle mass, muscle coordination, flexibility, all start to drop, often as a result of frailty, of aging, of the andropause, but also equally, sometimes it's diet, it's nutrition, this lack of normal exercises, and on top of that, neurodegenerative disorders. And what that does is that makes you more prone to falls, but also because you're less able to move from place to place, you go into this vicious cycle of less and less movement and more sarcopenia, more and more failure. So we go on to the next slide. Visual changes, of course, and that makes you prone to having trips and falls. And the problem with that is twofold. And if you go and do a home visit in an elderly person's house, you'll often find hoarding behavior. The house is completely littered with stuff. There are bags on the floor where the person has just about managed to come into the house and lost all energy, so they've just left a bag somewhere. Or they don't have the energy to actually tidy up and clean up behind them. So you end up with a house that's full of trip hazards. And then if you cannot see well, you're more likely to actually trip on those hazards and fall. Dry eyes, various other things with that, cataracts, glaucoma. This is less important, but yes, aging skin, and you have a couple of popular actors there, and you can see how they're changed. I'm sure there's some plastic surgery with Mr. B. Go on to the next slide. Malnutrition is very important, and this was found through the Dawes report in UK. From my orthopedic past, what we found was malnutrition was a huge contributory factor to frailty and then resulting fractures. So what we found that at least 50%, 30 to 61% of those who are hospitalized with falls and fractures actually are in a malnutritive condition. I looked at 786 consecutive hip fractures in Derby, and I found that a significant proportion of these patients, about 14%, had actually presented with a hip fracture and malnutrition within a year of losing their partner. So again, bereavements within the family lead to loss of interest, depression, a drop in diet with lots and lots of weakness and fall risk to follow. So let's move on to the next slide. And we all talk about these geriatric giants. Yes, so these have been mentioned before: the delirium, the intellectual impairment, the immobility. And once you stop being able to walk around much, it's just a vicious cycle. You just get more and more weak and more at risk. Because all your muscle systems and neurological control systems have started to fail, you're more likely to fall down and break things. Incontinence is a huge, big issue. So patients find that very hard to deal with, not just practically, but also there's a stigma and a cultural issue with it, and they lose confidence and don't want to go out. But also loss of swallow. So the risks of actually aspirating food into your airways and getting a significant pneumonia, which can be fatal, but also not being able to swallow, therefore not being able to eat, and therefore losing your body mass. So I just Googled old age is not frail, and I found this amazing lady in India on this huge big bike. So she's clearly old enough not to be on the bike. So I thought that's a good way of just saying that old age doesn't have to be frailty. Frailty doesn't have to be old age. Okay, so we go on to. So here we have Prince Philip and Queen Elizabeth. Queen Elizabeth is 94 and Prince Philip, I think, is 99. Okay, so there's a 5-year difference, which at that point is a huge thing. But one of them is not half as frail as the other one. So certainly over the last few years, what we find is that every time Prince Philip has a chest infection or a urinary tract infection, which he seems to have quite often, he ends up needing hospitalization. And if you look at them, 5 years difference after 9 decades of life, but their faces look completely different, don't they? And yet they live in the same household and have the same environment around them. So you have one person who is relatively a lot less frail than another person. So again, okay. So just to recap those first bits, if you're frail and if you're very frail, then just normal stresses in life can knock you off the perch and you can end up with a very bad outcome. Okay, so if you go on to the next. So again, this has already been mentioned by Dr. Maity, so we'll move on. So there's the cycle of frailty. Okay, so basically what happens is that we're getting old, we're losing strength and power, it's making us weaker, our balance is going bad, we're starting to fall, we're starting to not mobilize much, we're getting disabled, we're then getting dependent on other people for help. Our walking speed has slowed down, our activity levels have slowed down, we're not consuming much energy, our nutrition levels are going bad, our metabolic rate started to drop down, various control systems have started to fail, muscles have got weaker, bones have got weaker. It's a vicious cycle that just keeps feeding off each other. So when we try to think about how do we avoid frailty, we have to think about how do we get people off that vicious cycle. On to the next slide. So again, to remember, old age is not frailty. So I'll quickly mention my 3 patients from Friday. Had to get involved in a very difficult MDT with a 27-year-old boy who has cerebral palsy and learning disabilities. He is largely wheelchair bound and is prone to fragility fractures because he can't walk, it's largely indoors. He's looked after by mum and aunt. Unfortunately, the whole family have COVID. And we only found out when a carer went to the house and found that this boy, who is peg fed, had not had any feeds and not even had any fluids for 4 days because mum and aunt were hypoxic and totally flaked out in another part of the same house. So here was a vulnerable, frail 27-year-old, but he was not physiologically 27. Okay, so problem was cultural reasons. Mum and aunt were refusing admission. So then we had to have a multidisciplinary meeting where different people got involved, and we managed to get the aunt, who was probably the best off amongst the three of them, to talk and agree, and then get this boy admitted. Well, I shouldn't call him a boy, he's a young adult, but yeah, he had to be admitted, look after him. My next patient was a man who was 42 years of age, who pitched up to the surgery. He was brought in by his support worker. Why a support worker? Because he is an alcoholic. He drinks 8 to 10 cans of beer every day. And the support worker said he's not been himself at all. So I looked at this man, and he had mild ascites. He was obviously going into alcoholic liver disease. But interestingly, he was full of bruises. So I quickly bled him. And the problem with bleeding in a general practice situation is that I then had to drive down to Landock Hospital, the nearby hospital, and deliver the blood samples to the hospital because our collections had gone. His platelet count was 49. Why? Because of his cirrhosis, his spleen had got massive, and that was gobbling up all his platelets. So that was another frail person who had to be admitted. And by the way, when I was examining him, I found that he had developed what's called a gibbus or a kyphus. So he had, I'm sure when I see the report, which I haven't seen, he had a big crush fracture in his vertebra. So he was a 47-year-old who was already very frail and old. And the last patient, 82-year-old, husband's just died of COVID, dementia, has refused all medication for the last 10, 12 days. Family, because of COVID restrictions, have not been able to visit. So a complete spectrum of different people in different ends of frailty. Okay, so if we can move on. So the cost of frailty to the system is massive. So 2.3 billion is spent just on hip fractures from frailty in England every year. So that is that massive amount of money in rupees. So if you think then of the Indian population and you think about the cost, and that's just one facet of frailty cost. So it's actually a very expensive situation. If you move on. So what can we do about frailty? Well, we need to recognize it. We need to recognize that this is a condition, and not enough is spoken about frailty. Everybody talks about diabetes and this and that, but people don't talk about frailty, and it's very important. So that involves education to the patient, family, carers, and also healthcare workers. Try and prevent it. Try and stop the patient from slipping into those vicious cycles. Try and improve frailty by identifying risks and reducing risks. And it has to be a multidisciplinary approach. And there has to be lots of support systems. So if you go on to the next slide. So how do we recognize frailty? How do we diagnose it? Well, it has to be opportunistic. So every time you see somebody and you're thinking, are they frail? You have to try and work out, are they actually frail? So it could be in a clinic review. Maybe the carers can be trained up and they can say, oh, so-and-so is getting frail. Primary care, us as GPs, when we interact with patients, multidisciplinary reviews. Actually, even paramedics, the ambulance crew are starting to get very good at telling us GPs that they thought so-and-so was frail when they took them to the hospital. But equally, we should be able to train up the family members. And Dr. Maithi's mentioned a lot of things, so we'll go through this quickly. There's the timed up and go test. This is very quick and easy, and I use that a lot. And it's a simple test where you get somebody to walk about 3 meters, 10 feet, get them to stand up, walk, turn, and come back, and time them and make sure they're taking less than 10 seconds. If they're taking more than that, then you're worried about frailty and actually even falls risk. Next one. The 180-degree turn test is actually probably more important for falls because it shows how well coordinated somebody is. So basically, when you ask somebody to stand up and then turn around to face the opposite direction, normally you shouldn't have to take many steps, but if somebody takes 4 steps in turning 180 degrees, that means that their bodily control systems are starting to struggle and they are more at risk of falling down. Maybe it's a balance issue, maybe it's a control issue. Next, the walking speed also. So as we get weaker, the walking speed slows down. So if somebody's taking more than 5 seconds to walk 4 meters, then you're worried. It's a bit like the get up and go test. Next one. There is something called the PRISMA 7 questionnaire, and patients are often asked to fill these up. So, and if you score more than 3, then you're worried about frailty. So it's basically to do with your age, your sex, general health. Do you need people to help you out? Health problems, things like that. So the slides will be there. Similarly, there's the Groningen Frailty Index. All of these are based on lots of questions. Next one. It's not, similarly, there can be FSQ, which are patient self-reported questionnaires. Next one. This is the Dalhousie questionnaire, the clinical frailty scale, and this is used a lot. We use it a lot. Casualty units use it a lot because it's very easy. You have this mental impression of these people, very simple word diagrams, and it's very easy to fit people into it. And if you look at some of the studies, you can clearly see that as the CFS goes up, including mortality. Next one. So this is a very busy slide, and again, you can see this later. This is what's called a pictorial fit frame score, and it's very easy for patients to fill this up because they can look at the pictures and tick it, and then you then end up having a score. If you do it with patients, it's very quick. You can ask the patient to fill it up at home or in the waiting room, and it's a very quick, easy way to assess frailty. Nobody needs to be trained for this. And in the UK, you have something called the comprehensive geriatric assessment, which is like a 360-degree assessment, which looks at the patient's medical, mental, functional, social, environmental things to come up with a care plan. Okay. So going back to those early bits, the education about frailty. So, well, all of these people need to be educated: the patient, the carer, the healthcare workers, GPs, physiotherapists, the family. I'm presuming that you geriatricians are already well aware. So it's us lot that need to be trained. And how do we prevent it? Well, we have to manage chronic disease better. So the way it happens in the UK is that us general practitioners have a carrot and stick thrown at us by the health system. We have to carry out regular surveillance of patients' chronic disease and regular surveillance of the elderly. So we were worried very much through COVID because of social distancing and shielding, that a lot of the elderly people we never got to see for long periods of time. So that's one of the side effects of that they've possibly got more frail or more ill. So we have to work out other ways of doing a lot of these. Exercise. So we have something called the Community React Team, the CRT, which who have physiotherapists who are trained in frailty work, who can go into patients' houses and teach them very simple strengthening, conditioning exercises. They just need small amounts of regular physio. Diet is very important. So a community dietitian service, not only to improve what the patient's eating, but making sure that they can swallow and eat properly. And that surveillance, which is part of that carrot and stick. Supplements, which is a little bit more controversial, but can it be done? Okay, next slide. So again, what do? We try and stage them early. We try to recognize their risks. Falls prevention is very, very important. So for that, there are ways and means, and that's a whole new topic, so I won't go into that today, is recognizing somebody's falls risk and then trying to prevent that or improve it. So work on their vision, their mood. Very important to look at medication of people who are frail, because remember, they are more at risk of side effects. So do they need the drug? Are they on the right dose? Are they on a way that they can actually take the drug? Are they getting confused? You often go to a house and you find a huge bag of medication that they've not taken. So should they be on pill boxes or Dorset boxes? Or do they actually need a carer to give them the medication? Do they need walking aids? Do they need hearing aids? So all of these things. reducing hazards in the house. So we go on to the next slide. And with age and frailty come big financial risks. So financial stability and planning is very, very important. I've just had some coffee, which means I'm less at risk of Parkinson's. Attorneys. So very important to identify dementia and frailty early and plan for family members to have lasting powers of attorney to take decisions for patients when they can't take them anymore. Having that comprehensive assessment and then putting care plans in place to protect people from vulnerability. Make sure they're not getting bored and fed up of life, so some sort of entertainment. Next slide. So there's so many things that end up needing help. So it's a big multidisciplinary thing in the ideal world. So you have the patient, the carer, the family, all need to be educated and understanding the problems. The general practitioner, they have to look into the situation and have a package of care which is ideal for what the person needs. So it is patient-centric. We have a frailty nurse that we as a geographic cluster of primary care practices have bought. An amazing lady called Shiva who goes to patients' houses. She has a lot more time than we do and she can carry out her assessments. I'm forever bombarded by emails from Shiva saying, Dr. So-and-so, so-and-so, I'm worried. So it's like she allows us to have a chronic look inside a person's house. Availability of physiotherapy. And all of this that we're doing in the community has to tie up with the hospitals and the elderly care services. And a lot of this is done through falls prevention clinics and the day hospital. Community dietetics to look at nutrition. Pharmacists to help us with delivery systems to make sure that they have very clear medication boxes. Do they need it in an oral form, a liquid form, a dissolvable form, things like that. Old age psychiatry, but even not for a frail elderly, but for a frail young person. Frailty is a huge mentally taxing condition. So it's very likely to come with depression, frustrations, and anger. So psychiatry help. Occupational therapists to look at adaptations, walking aids, changes to the environment around the person to make sure that they are less at risk and can do the activities of living easily. Next slide. And outside the healthcare setup, community organizations. So again, talking about COVID, we found that the elderly were terrified or being told to shield. So they couldn't go and pick up their medication. And this carried on for a while for us. It was a big problem until we found that there was a community organization that was happy to deliver medication to patients' houses. That's just one example, but community organizations. So Dr. Raha and myself are involved in what's going to start very soon. We're going to deliver through Zoom yoga, meditation to people in our community here in Cardiff to keep them entertained, engaged, fit, excited, all things that prevent frailty. Silverline is a service available here in Cardiff where an elderly person can pick up the phone and ring somebody who has an insight into age. Similarly, clubs. So I've actually found knitting clubs really helpful for frail old ladies. Befriending services, help alarm systems, so important. So the couple that Dr. Maity spoke, whose children are far, far away from them, if they run into trouble, they need some kind of a help alarm system which can quickly alert somebody. And patient advocates who can look after their needs. Next slide. I don't know how I'm doing for time, so I'm not going to go into this in details because again, polypharmacy and rationalizing medication is very important and it's a huge topic by itself. But as people get frail, as their bodily systems fail, as their urine output fails, as their liver starts to get weaker, as their mental state and the quality of their brain starts to deteriorate, they get much more susceptible to problems with medication. But also equally, because they have all these medical conditions, they are on a lot more medication. So this is a funny problem, a chicken and egg situation where you need more medication and therefore you're exposing them to more risks. So as doctors, it's so easy for us to harm patients this way. And there has to be in place in every system a frequent medication review procedure. And that's really important for people who are frail. Now we have to ask ourselves, do they need this medication? Are they taking it? Why are they taking it? Do they still stand to benefit from a medication that they used to take before? What are their new risks? Do we have to change their doses? So these are all questions, and there are lots of tools, stop, start, no tears. Doctors in India, you can always Google these. They're really helpful ways of trying to rationalize what somebody needs. Go on to the next slide. Again, it was a polypharmacy slide, I think. Very busy slide, so ignore that. But just remember that some medication are high risk. And there are some factors. We are asked to ask the golden question, and that is a really difficult question to ask. And the golden question is, would we be surprised if the person we are visiting, the patient we are seeing, does not make it beyond the next 6 to 12 months? Okay. If we think that is the case, then we have to think more in terms of symptom control and worry less about medication that are for long term. And yeah, so if we go on to the next slide. Again, this is about interventions, and the evidence and the financial analysis of interventions actually show that more cheap and cheerful things are actually more helpful. So strengthening exercises and nutritional supplements, or just simple mixed exercises that anybody can do, like a walk, going out with somebody, health education, and a community, a frailty service home visit is probably more helpful than an expensive hormonal supplement, things like that. Okay. So thank you. I know I bombarded you with a huge amount of stuff. All I would like to say is that, why is a former orthopedic surgeon interested in frailty? I was just like everybody else, a very mechanistic person interested in orthopedics, wanting to learn these procedures, until I suddenly started to see these huge amount of elderly people who were incredibly frail on the wards. I was very lucky that my first orthopedic consultant, Mr. McClellan, was actually one of the fathers of orthogeriatrics. He actually pushed the Royal College of Physicians in their first working party in the 70s, saying that these people who are coming with hip fractures are dying for, not because they had a fracture, but because of their various medical frailties, and they need different kinds of cure. And this gentleman used to tell me, I'm very happy with how you can operate on these people. What I want you to do is to sit for some time with these patients and find out how their medical condition, their frailty affects their day-to-day life, and what you then think would be needed for them afterwards. And that was an amazing lesson. Initially, I thought, why is he telling me this? It took me quite a few months actually to understand the importance of looking at a person as a whole. And the only other thing I would like to say is that when I moved specifically to hand surgery, I found a huge amount of ageism with medical interventions. And that's because we as doctors were using wrong tools to assess how someone recovers from an intervention. So the elderly were asked to use JMR grip dynamometers, but that's not important. What is important is, what does a frail person need? A frail person might just need to be able to use a keyboard or a joystick for their wheelchair, might just need to be able to open a can or open their door lock. So actually, one of the big papers I did where I looked at 800 odd carpal tunnel surgeries. It was a multi-center study in Baltimore and in Derby. And we used something called the Solomon table, where we recreated normal, simple things that an elderly person would have to do, and proved that actually the therapeutic effect for something as simple as a carpal tunnel syndrome decompression, which was not offered to a frail elderly person before, was making a huge difference to their life. So the reason I mention that is because when we think about frailty, we have to think 360 degrees. We have to think beyond our traditional means of measuring disease and weakness. Thank you.
Thank you, everybody. And we are quite on time. I'm very happy to say that. And we have a lot of questions. And I think, Dr. Raha, you've responded to most of the questions. And just one thing I wanted to mention is Dr. Shyam Chakraborty could not join because of some technical glitch, but he's very much there. And I'm sure he's going to send an email, telling us what to do next. That'll come later on. So from here, and going by all the questions about Alzheimer's, dementia, I think we probably need to have one entire webinar on that. So the thinking now is, I'm a functional medicine consultant. So in my world, we look at prevention of dementia rather than treatment, because treatment is not my specialty. That is Dr. Raha's specialty and Dr. Sinha's and Dr. Maity's probably. So yes, dementia can be prevented. It starts 20 to 30 years before, but there are a lot of strategies and a lot of things that you can do for yourself. So maybe we'll leave dementia for another session. More importantly, Dr. Raha is available as to consult with on the Trinnect platform. But Dr. Sinha, I don't think you are available. Am I right?
I will become.
Okay.
I have my own health needs, and I'm trying to rationalize my workload at the moment. So once I've sorted this out, I know I look very cheerful and this thing, but I have a slightly unhappy spine, and I have something called myelopathy. So there are various issues. So once I rationalize that, I will become available.
Sorry to know that, Dr. Sinha. And I think your sense of humor has actually helped your healing in a great way. And
Yes.
Well, it's essential, isn't it?
Yes. And Dr. Maity, how can someone get in touch with you? Are you sharing your contact details or anything?
Yes, I can. My email address
you can just
there.
type your email in the chat box and address to everyone. And thank you. Have we missed any questions? I know there was one question about age. I think that got answered.
Yeah,
I think one of the commonest question was obviously with Parkinson, age and frailty and dementia, which is dementia going to take over the topmost cause of disability and death in the world in next 20 years. And particularly the countries which have got a very large population, like India and China, has to face this. And it will be very difficult to prevent it, because although, as Shabnam says, that there are preventative strategies, but the preventative strategy has to start 20, 30 years upstream. You can't start the preventative strategy when you're diagnosed or you are in very early stages. And the problem with the neurodegenerative disease is that there can be combination of neurodegenerative disease. Like a lot of my Parkinson patients, when they develop dementia, we say that this is dementia because they had Parkinson for 5, 7, 10, 15 years. And there are certain types of functions which are affected first in Parkinson's disease dementia, then cognitive function, then the Alzheimer's dementia. But everything is not black and white. Medicine is very gray. And you can have Alzheimer's dementia along with Parkinson's dementia. So that's a double whammy neurodegenerative condition. So those are the challenges in day-to-day clinical practice.
Thank you.
Can I ask Dr. Maity, Shabnam, Dr. Maity, what's happening in India with regards to availability of geriatric care? We had very difficult experiences with aging relatives, with actually all the things that I mentioned. It's like there seemed to be a difficulty in getting somebody who had a geriatric overview of treatment.
You are absolutely right. At first, I'd say Dr. Sinha and Dr. Raha for a very fascinating talk. We really enjoyed. Regarding geriatrics in India, yes, India is in infancy in that sense. Actually, I worked in NHS for 15 years and trained in geriatrics and general medicine. Was a consultant in geriatrics before coming here. So in there is a sort of boost from government and in private sectors to address this issue, but it's, as I said, still in its infancy. And you know that geriatric care, not only the medical issue, it's a lot of multidisciplinary aspects there, financial, social, functional, lots of things there. So we need a sort of organized sort of service to address all these issues. So we as geriatricians here, actually, it's very difficult to organize all those things unless there is a big sort of boost from the government or your private sector. In the private sector also, things are very patchy. Okay, so in not that organized fashion, but we are trying. We're trying our best now. Gradually, actually, the importance of geriatrics has been recognized. The number of MD seats in different hospitals are now increasing, and number of trainee coming. The sort of thing that is going on. And we as a, I am the chairperson of the Geriatric Society West Bengal branch. So we are organizing, but not in this COVID situation, but we are organizing some regular meetings and things that will improve public awareness and providing service sort of thing. And GSI India, we are having regular annual conferences and meetings with international collaborations and things. So the things to actually, as Chatfire you said in your presentation, that we have to know there is a need. So that's what inform people that there is a need there, and how to meet that. That's the next step. So that people's awareness is most important. So that thing is actually happening here. But compared to UK or the Western world, it's not at all. You know, that like you have to go miles to go before we sleep, sort of thing.
But it's great that people like you have gone back and you're getting involved in awareness and training and teaching, and that is, I think, very important.
I have a question, because given that I'm the only woman amongst the panelists, and this question is open to all of you, there is a difference between how women age and how men age. That is one thing which, and I'm a former OBGY, and the differences between sex and gender, and particularly in relation to diseases, is something that we are becoming aware of now. So women actually behave quite differently in comparison to men in terms of drug response and a lot of things. And gender is more cultural. It's like how sometimes the women don't get as much importance in terms of their illnesses and things like that. It's not everywhere, but as physicians, I think we have to be aware. Yes, we have to be aware of the difference in both in men and women as well. And another question I had to all of you is, given that in India, people become sicker at a much younger age. We know that cardiovascular disease is at least 10 years before the rest of the Western population. Do we also assume that, you know, frailty and all these problems would occur much earlier? And given also the fact that South Asians, as it is, have a problem with muscle mass, they have much lower muscle mass, muscle that doesn't work as well. So whoever would, I mean, if all three of you want to chime in, it's fine.
Yeah, I can tell you, yes, I think racial factor is one important factor. There is no doubt about it. And obviously there is a developing country, developed country. So, and the race, as I said early. So that's why the definition of genetics is different as well. Here we, in the developing country, we use 60 years above. And whereas in the Western world, it's 65 and above. So that difference is there. The nutrition is important, socio-economic backup ground is important, and then obviously the disease burden is also that. Suppose chronic diseases like diabetes, hypertension, COPD, CKD, and things like that, those are not dealt with properly from the beginning, sort of thing. So there are advanced disease states are there as well. So people here in the developing countries like India, yes, they grow older earlier, they develop frailty earlier compared to the counterpart in the developed countries. So that I think the multifactorial issues there, and also the cultural issues. People when they are 50, 55 years here, they think themselves old. So that's a mental state of it as well. Where 85-year-old in the Western world, they're thinking, okay, no, we're fine, and that sort of thing. I think Dr. Raha might add to things actually, or what he thinks, or Dr. Sinha.
I think, thank you, Shabnam, for your question about the male and female. And in fact, even in COVID pandemic, it's very widely shown that how male are more affected and having more adverse outcome than females. And that's true, particularly in Parkinson disease. In terms of protection, I agree that there are lots of different factors. But as far as I understand, there are many neurodegenerative conditions which protect you more because of your hormonal reserve till menopause. And that actually is true for many things, including ischemic heart disease and possibly dementia as well, and neurodegenerative condition. In terms of perception of old age, I think as far as geriatric medicine is concerned in UK, I will certainly liaise with Dr. Maity further, because I'm at present chair of the British Geriatric Society's Wales branch, and we are actually talking about forging some relationship with India in terms of geriatric medicine and how one can support each other. So certainly we'll be in touch with that. But concept of geriatric is so much different because that's cultural, isn't it? Culture plus media and exposure. Like I had people in my ward who will refuse to go to care of elderly ward, even if they're 95, So, and their family will argue that why I want my mom or dad to take to care of elderly ward. But so the concept is also quite important, and it is not going to change overnight. In terms of what's going to happen in future in India, I don't know. I think that health problems are going to get worse because of the automation, because of the fast food in the present younger generation. And on the top of that, now we've got working from home. So all those will probably, this working from home will probably continue to some extent, even after COVID is gone, and that will have its own health implications.
Thank you, Dr. Raha. So Dr. Sinha, would you like to add something to this discussion?
I think the gender question is quite interesting, isn't it? And it's interesting how gender is a big role in almost every disease system, life, also how one thinks. I'm quite lucky with where I work. So it's a small practice. There were 6,000 patients, but it's an incredibly mixed practice. So my patients can be anything. They can be Tigrinian. I didn't even realize that there was an entity or a language called Tigrinian, which is largely people who had to flee former parts of Ethiopia because of to Indians all over. So at least 46% of my patients are not kind of the typical British population. So we see a lot of health beliefs, and the health beliefs have to do with everything from the reaction to aging, how much support you have at home, equally how much impediment there is to health interventions that help from people who are trying to help you at home. A complete lack of understanding about chronic disease. So with Dr. Raha mentioned earlier, with a lot of chronic disease, just because you're starting to feel better doesn't mean you stop taking medication. On the other hand, for a lot of chronic disease, medication should be considered to be a stepladder approach. So when you're worse, things escalate. When you improve, things deteriorate. Or the amount of medication you take slightly drops down, especially with airway conditions, diabetes even. But that is something that I find that there's a big cultural problem, especially with Asians. There is a lot of health anxiety and the belief that medicine is the God's gift to everything else. and other simple but more effective health interventions like exercise, diet control, and things like that are just looked down upon. So there's a lot of education required for that. And that doesn't change even a generation or 2 generations into changing completely and moving to another part of the world.
Thank you. Thank you to the panelists, to the speakers, and thank you to our wonderful audience. You've been really very encouraging. Questions are always really interesting because otherwise it gets kind of boring. Thank you for, bearing with us for 2.5 hours. Thank you very much. Really appreciate that. And Dr. Maity is back. One more thing I just wanted to say, because I'm very interested in health technology, and I'm sure Shyam could have added some if he could have joined in. One thing that really excites me is technology is a great leveler, because my medical practice is through teleconsulting in India and I live in Canada. So what is interesting is a lot of the technological advancements that are going to come up in the near future are going to be easily, deployed in countries like India, where we have, very good mobile connectivity. Internet, well, I won't say quite as much, but the thing is, and we have a lot of people who are open to trying out different things. So how elderly people can be taken care of at home. Now, telehealth is one of the best things that could have happened, because like, all of you, I have gone through, my mother-in-law is 91. And you know that when you have to take an elderly relative to a doctor, like even if when I am a doctor and I kind of get a preferential treatment, it is still the waiting room is like not comfortable enough. I'm talking about Mumbai. So it's like there isn't enough space. There may not be enough access. So all those things, a lot of those problems can be taken care of by telehealth. And of course, Trinnect is, helping in that in a very big way. Thank you very much, everybody. And we are going to sign off here. And that was a wonderful session. Thank you, everybody, for chiming in.
Thank you, Shabnam.
Thank you. Thank you.
Yeah, I wanted to say the same. A big vote of thanks, everybody, to Shabnam. Very well organized. Thank you so much. She has earned the right to have her favorite tipple.
This is morning.
And all I can say is that I think Shamda is probably frozen because yesterday he said it was -18.
Oh, okay. We have a few
Thank you.
messages. Your brother lives
Thank
in
you,
Toronto.
Shabnam.
Oh, thank you. I live in Alberta. That's far away, but wonderful having you here. Thank you, everybody, and bye now.
Okay. Thank